Thank you. That was unduly flattering, but it's a pleasure to be here, a real honor to be at this esteemed center to talk to you all about pulse field ablation. And really what I'm going to do in this talk is not blow your minds away with Kaplan-Meier curves and articles published on pulse field ablation, but sort of step back and give you guys a basis of where this story actually started, why this started in the 70s but never really took off, and how it came to being, and what we are doing today, and what we see in the immediate future. And the next slide that I'm going to show you is a slide that I was just chatting with my son last night. Oops. This is 26 years ago. I was a young intern, and me and this guy here who somewhat cut off, we decided to go and work with this pediatric surgeon in a leprosy hospital on the border of Bangladesh. We spent 2 years there doing all sorts of surgery and procedures, treating rabies, leprosy, malaria, and a lot of my medicine is learned at that place. And I always remember those years, which were really formative for me, and I just felt like remembering him. And thankfully to the patients in that area, these two guys stayed on and built out this shack into a big hospital and nursing school that's serving the community there. And by the way, this hospital, a lot of the equipment was from MASH, donated from the Mobile Army Surgical Hospitals, which is the connection here with Dr. DeBakey. These are my disclosures and a special acknowledgement to Dr. Watanabe, who's our current postdoc, and to many of the other postdocs who've been in our lab over the last 15 years. So I want to take a step back and talk to you about arrhythmia interventions. Look, in the 70s and 80s, we did surgery for VT. You could have a surgeon do cryoablation of the AV node, which was the only way we could treat SVTs. But in 1981 came a technique called DC ablation, where you gave this massive dose of energy to the His bundle. And it actually worked, but unfortunately, and I'll show you on the next slide, patients died from this technology. So while successful, it had pretty awful side effects. At the same time, the surgeons, as they do today, had various procedures to control atrial arrhythmias besides the surgery for VT. You had left atrial isolation procedures such as the corridor procedure, and look at this surgery where you have the right atrium in sinus and the left atrium in AFib. And now the MACE procedure that is still practiced today. Now what's the story with DC ablation? DC ablation is this technique where you generate these high voltages through these catheters, and one issue is it causes electrolysis and releases gas from the catheter. And these gas bubbles are insulating, and when they coalesce, electric current then forms plasma. So you get these vapor globes like depth charges that the submarines used to use that cause damage to the myocardium, and that's why patients died from this technology. Moreover, you need a deep sedation. There was a lot of muscular stimulation, like a massive cardioversion, and it really wasn't a very popular way to do things. And while there was lots of research to make it better, there was something called low energy DC shocks, which is actually very similar to today's pulse field ablation. The reputation of DC ablation was already down the drain, and this led to radiofrequency ablation being developed, which was much more precise. It was a nice little catheter that delivered the technology. You didn't get any muscular stimulation. You could do these cases with or without mild sedation, did not need neuromuscular paralysis. And in the days of cardiac cath, this seemed to be a much preferred technique. And obviously we know how WPW, SVTs, VTs were treated with RF. And we also know about the advent of AFib ablation once Dr. Hasegaer talked about, research and taught us about PV ablation. Now, when you think about interventions in EP, you have all these interventions: lifestyle modifications, pharmacotherapy, pacing, autonomic modulation. A lot of that work was done by Dr. Valderabno. But when we talk about ablation, just remember this is a destructive treatment. Sounds inelegant, but surgeons use it all the time by excising tumors. And this is done by delivering energy. It could be radio frequency, freezing, laser, microwave, ultrasound. You can inject alcohol. You can have a surgeon do the ablation. And our targets are usually abnormal foci in these arrhythmias or abnormal regions like in the PV or in the scar in an ischemic heart. But if ablation is the one option that we pursue, which is currently the big invasive treatment for arrhythmias, we need a tailored ablation that addresses all depths and widths. We need precise targeting. In the era of AFib and VT, we need rapid, large, and wide lesions. We need rapid, narrow, and deep lesions. We need to be able to slowly titrate these lesions so that we don't unnecessarily kill tissue. We need to know when we are done, whether these lesions will be durable. And most importantly, in today's day and age, we need great safety, and we need to be super efficient because of the volume of arrhythmia patients that we have to intervene on today. And this is just a list of all the technologies I've been involved with in the last 15 years, starting with startups, big companies, catheters that came and said they would change the practice of EP. This was a laser balloon. This was an ultrasound run by a robot. And every time I worked with one of these companies, I was like, this is it. This will solve all our problems. But the one problem that we had with heat was that every time we got more aggressive, we paid a safety penalty. And after 20 years, we really got good at using radiofrequency. But the safety penalty issues is what always held us back. These were the challenges with thermal ablation. We had gaps in our lesions. They weren't wide or deep enough sometimes. It was time consuming. And more importantly, every time we placed a catheter in the heart, we were at risk for stroke and tamponade. And these three problems really plagued me in my days of AFib ablation. The risk of phrenic nerve injury, fistulas that seemed to happen quite randomly and almost always were fatal, and pulmonary vein stenosis. Three issues that always changed the aggressiveness with which we could do an AFib ablation. So enter PFA, the latest and greatest energy, and my hope is that at least for the next 20 years, we don't have to learn another new energy and we can just perfect this one. Its basis comes on two techniques: reversible electroporation, which is used in biological research and therapeutic applications, and irreversible electroporation, which is well used in oncology, and people knew that there was something special about electroporation. You could damage a tumor and spare the blood vessels in the nerve. So this was always there in the background while radiofrequency was evolving. The way to think about electroporation is really short, either microsecond or nanosecond pulses. You create a large voltage gradient across a cell. What that does is to create pores, these gaps in the cell membrane. If that voltage gradient is below a threshold, these pores reseal. That's reversible electroporation, the cell lives. If it's above a threshold, and that threshold is different for different tissues, for different waveforms, these pores stay, and then the cell dies. It's not just the pores that disturb the balance of the cell and kills the cell. You also oxidize and damage the channels. And once the cell membrane is damaged, the cell dies. When the pulses are much narrower in the nanosecond scale, it's not just the cell membrane that's getting disrupted, you're also disrupting the organelles of the cell. So a different mechanism with different pulse widths. This is a timeline for how you kill tissue. When you burn tissue or cook meat, you see the change happening real time. But with PFA, right in the moment when you deliver tissue, nothing changes in the tissue. What happens after you deliver the pulses is over seconds to minutes, the cells start dying, and in a few hours, the cells are completely dead. And what you can see as early as an hour after delivering this pulse is that the cells are all destroyed. You have contraction bands because of contraction of the cytoskeleton, of the actin and myosin. Mitochondria swell up, the nuclei get deformed. But what you see is sparing of blood vessels in this EM slide from our data. And what's really remarkable is, even at an electron microscopic level, you can see a line of demarcation. Everything to this side is dead, and everything to this side is still alive. And this sort of precision is driven by that threshold of the field. These are what pulses look like. It's electricity, so all pulses will stimulate the heart, like pacing. It'll stimulate muscles and nerves. If you don't design your pulse well, you'll be in this reversible phase. You'll stun the tissue, but the tissue recovers. If you get it right, you create a lesion. If you overdo it, you start burning tissue. So you have to live in this little space to get all the benefits of PFA. And this is a picture of a catheter. This is a metal tip that's releasing a pulse field sequence. And this image is something that I want you to keep in mind and contrast this to a radiofrequency lesion. This is a thermal camera showing you heat spreading slowly over time. And this is 30 seconds compressed quickly. And you can see how the lesion slowly progresses. The way to think about pulse field is turning on a light bulb at the end of a catheter. In one instant, in a few seconds, you create this electric field, and everywhere it's light blue till dark blue, anything in that region gets ablated. So you need to push hard into the tissue to drive the blue into the tissue, but while it sits on the tissue-blood interface, it's also exposing blood cells to this electric field. So if you have a piece of myocardium that's sort of bouncing around in this white zone, even if the catheter is not touching, if it gets exposed to this field for long enough, you get ablation. And this is important to understand because I'll show you some pictures to drive home why pulse field is likely the best energy source that we have. Another thing with pulse field is this problem with reversible. So when we deliver a lesion, at the time of delivery, in the lab, when we do pulse field ablation, we kill tissue, but also reversibly stun tissue. So at 0 minutes, you get a wide area of electrical silence, but a day later, the lesion is only this much, which is why we need to know going into the case what the size will be so that we overlap lesions so that we don't end up with gaps. This is one of our early papers where we did histology after surviving a series with the first catheter that brought PFA to this clinical space. And what we saw in the sea of fibrosis was a preserved nerve and an arteriole with a little bit of hypertrophy, which basically recapitulated data from the urology literature where they were doing electroporation of the prostate and preserving autonomic function. So PFA seems to kill tissue with sparing of the vessels in the nerve. But maybe the most important thing, pulse field, it kills the cells, but the extracellular matrix, the scaffolding upon which these cells rest, the fibrous tissue, that's preserved. It's almost like a vacuum cleaner coming and taking the cells out, but leaving the scaffolding in place. And that is why tissues don't fall apart. You can make a through and through lesion in the left ventricle and not be worried about free wall rupture or ventricular septal defect, because that matrix that holds the tissue together is preserved. This is a comparison of a pulse field lesion and an RF lesion. Because the mechanism of death is the same, electroporation, and because the field is uniformly deep, all the tissue dies and heals at the same time. So you get fibrosis at 2 weeks, and up here and down here, it looks pretty much the same. But look at a thermal lesion. You have some necrosis here that's getting resorbed, mostly necrotic tissue here, fibrosis here, and because the heat didn't make its way down here, you have some sparing of the myocardium. And this is a good contrast of why pulse field, when delivered correctly, is going to do a much better job of making a lesion than radiofrequency. Now, we keep hearing about PVI being so important, but this is an experiment that we did from years ago where we did a radiofrequency PVI in a swine. This is the right pulmonary vein opened up. You can see the lesions, a little bit of browning here, some narrow, some wide, but we did a good job. And this is the distal vein that's been isolated. But you can understand why if I make one small mistake, there may be a gap across this lesion and a reconnection. And this is what a PF lesion looks like. This is the SVC opened up. You can make large lesions very quickly, and they're so large that overlapping them is easy, so the chances of a gap is much lower. And if you have a catheter that's designed like a balloon that ablates all over the vein, look at this vein. It's been completely ablated. So if you ablate the whole vein without penalty of phrenic injury and stenosis, how can you get PV reconnections? So PF allows for the first time for us to get durable PVI. Now we're in our first generation of devices. We aren't there yet, but if we can do this consistently, we will get there to durable PVI. Okay, so again, let's look at ventricular lesions. This is the new thing in EP, using PFA in the ventricles. And again, just keep this picture in mind and look at this swine ventricle. If I were to use a radiofrequency catheter that's like a little pencil, and I were to force it in here, it would slip into this recess and start burning from the inside and slowly grow out. So sometimes when we open the heart, we could not even see the RF lesion because it's buried deep in these crevices. Whereas with pulse field, if you place the catheter here, everything within that glow gets ablated. And that's why you can get these trabeculae ablated so well, something that's almost impossible to do with radiofrequency. This is an important concept with radiofrequency. As you burn the myocardium on the left atrium by the mitral isthmus, the cool blood flow in the coronary sinus prevents the roof of the coronary sinus from getting ablated. That's called the heat sink effect. It's cooling the coronary sinus roof, so you can't burn it, whatever you do. With pulse field ablation, because it's the electric field and has nothing to do with blood flow, you can go right through the roof to the roof of the coronary sinus. Now, animals always give us a projection of easy ablation, and there's always a fall off when it comes to patients. So for the right catheter and the right dose, this will be achievable in patients. We just need to get there. What about scar? This is work from our lab, corroborated by many others. This is an ischemic scar, and even though scar is conductive, getting heat or cryo to penetrate through scar has always been challenging. But because this is all electricity driven, you can get a pulse field lesion going right through the scar. This white spotted area that's beyond the scar is a pulse field lesion, and you can see these lesions penetrating through scar. This is a thick, dense scar made with PFA, and you can see how the acute lesion has gone right through it, almost as if the scar didn't exist. So if we are targeting scar tissue, pulse field is the way to go. And just pay attention to this particular slide. Everything in the black dotted region here is ischemic scar in a swine ventricle infarct model. And these are the surviving muscle bundles. That's where we place the catheter, and everything in the yellow dotted lines is a pulse field lesion. And you can see how this surviving bundle is bright red. It's not ablated, but these bundles were ablated through and through. And that is why we think that PF is truly equipped to answer scar VT effectively compared to current technologies. What about the esophagus? This used to be a horrible problem that drove us paranoid. It changed the way we delivered RF. It led to reconnections because we wanted safety. So what we did in this experiment was to actually ablate from the inferior vena cava against the esophagus in a swine model, and we recapitulated a fistula. This was a swine that developed a smoldering infection and had a connection between the IVC and the esophagus. But when we did the same thing with pulse field catheters and checked after 2 or 3 weeks, we didn't see any lesion anywhere. And we thought at this time, wow, PFA spares everything except the myocardium. But we were wrong. What we didn't realize was if you looked 2 days later, you could actually see the lesion. Here you see the lesion. But what's magical about PFA, I shouldn't use the word magical. What's special about PFA is that because the extracellular matrix is preserved, everything heals and you see no trace of the lesion. And that's for the gut, because the gut can regenerate as opposed to the heart. And that is why we still think that fistula formation is very, very unlikely as long as the catheter delivers PFA. We did report recently on a single case, and this is after a million cases of PFA were done. And what we are seeing here is hemorrhage, and I'm going to play that thing again. And what we are beginning to appreciate is that if we don't use catheters properly, you get these little sparks. And these are mini versions of what we saw with DC ablation. These arcing events are plasma discharges that can get really hot. So if you use a catheter improperly and have the electrodes touch each other, you can get these arcing events that can, in some cases, cause damage. But this is just that one case report. Maybe this was not related to this, something that we have to keep an eye on. But so far, this has been the only report of esophageal injury. What about nerves and ganglia? We can stun nerves, but the nerves always regenerate. We can stun and stimulate ganglia, but the ganglia typically are preserved. And that's not because PFA is something special. We're just too far away from these structures to damage them. If we took a needle with PFA and jammed it into the nerve or the ganglia, we can ablate them. But from the inside of the heart, we seem to spare the ganglia, unlike radiofrequency that could affect the ganglia. Venous stenosis. This is an important thing because in the days of radiofrequency and cryo, we went through great lengths to stay out of the vein. And when we didn't, we ended up with stenosis. And multiple preclinical and now randomized studies and multi-center studies say, and have shown to us, that if you put the catheter in the PV and ablate, you do not elicit a stenotic response. And remember, radiofrequency creates thick, tough scar, and pulse field causes thinner scar. There is a qualitative difference between the scar between PF and RF, yet to be published. This is something that all of you EPs who do clinical cases appreciate, how difficult it is to ablate when a structure is moving in the heart. Papillary muscles and the moderator band, infamous arrhythmias and targets that are very difficult to ablate with radiofrequency and cryo. And here you can see, as long as this blue and white zone involves the tissue, you can make really good lesions and affect all these little branches, sometimes which are very crucial to the sustenance of these arrhythmias. Now, coronary spasm is a big deal. We've always known about this from the oncology literature, from prior literature, but pulse field causes local spasm that always recovers and is short-lived, 5 to 30 minutes. And it's a proximally related class effect. You can see that despite delivering pulse field over the epicardial fat, over the LAD, the lumen of the LAD is preserved, something that you can't do with radiofrequency. You'll often cause a thrombotic lesion if you heat the tissue. And you can even penetrate the fat and cause a shallow lesion with PF. But what we learned in preclinical studies is that as the pulse field went through this coronary, it wasn't completely benign. You actually caused fibrosis of the muscles because they get electroporated, and you got some intimal hyperplasia. I'm going to take a step back so that you all can appreciate how we got here. This is a really cool story. This is Stephen Mickelson, a EP from Iowa, who came up with the idea of, hey, why don't we use pulse field ablation to do AFib ablations? And this was the initial iteration of the catheter that you all know as FARAPulse today, was an epicardial catheter that we used to place in open chest animals, take it all the way around the left atrium and strangulate the PVs, and with a single shock, we'd ablate the entire posterior wall and the pulmonary veins. And this is a Heart Rhythm poster in 2016. Little did we know that ultimately we'd abandon the epicardial approach and go endocardial. And I still remember when we did the first series with Dr. Reddy and Newsel in Prague, it was so amazing to see the PV potentials go away in a few seconds compared to the minutes-long procedures that we had done all these years. But little did we know is that our dose was not good. And as we were doing the proofs for this paper, these patients were coming back with PV reconnections. And that's when we noted that acutely things may look great, but if you don't have the right dose, you get reconnections. Back to the spasm story. What we now know is that spasm preserves the lumen, does ablate the tissue, the wall of the artery, but radiofrequency does the same thing. except that it doesn't cause that much spasm. It ablates the wall just like pulse field. And given that we've been using radio frequency for so many years without major issues, we think this is not a big issue. There was a recent paper that looked at OCT and said that this hyperplasia that we saw can affect the luminal area about 10%. But 2 studies since then have shown that largely the coronaries a year out, despite this change, remains okay. What we are now struggling with, a new complication, is this report. We know that pulse field ablation can cause spasm if you're close to a coronary, either endocardially or epicardially. But this was the first of many reports where after a pulse field ablation procedure, 45 minutes later in the post-procedure area, you had a patient who go into complete heart block with ST elevations. And when they shot the coronaries, we saw diffuse spasm. And this was not because the operator was ablating near the coronary. This is back in the left atrium. And it seems that in a subset of patients, you elicit this diffuse Prince-Metal type reaction. And it's very difficult as of today to predict who this patient's going to be, why exactly we are having this, what are the mechanisms behind it, how best do you treat it. Obviously, you treat spasm with nitroglycerin. But while many of these cases happen in the first few hours after the procedure, there has been a subtle indication that when these patients go home, there may be a slightly higher risk of sudden cardiac death. We don't know the mechanism of this sudden cardiac death that's been reported through the FDA databases, but something for us to keep an eye on. And just to caution you, this is an extremely rare event. I mean, not many of our labs that have been involved with pulse field for many years haven't even seen one case yet. It's in the order of as infrequent as a as an atrioesophageal fistula, but something for us to keep an eye on. Hemolysis, just remember, every time you have a catheter in the blood pool, you're ablating red blood cells. This was an issue initially when we were being very aggressive. This is largely being solved because now we are more careful about getting good contact and not ablating the blood pool. And many of the newer catheters just don't cause hemolysis. What are the challenges? Acute assessment of durability. How do we know when we are done that we are truly done? Will all this PVI remain durable over time? We've talked about hemolysis and spasm. Late onset vasospasm. Sometimes PFA can terminate arrhythmias without actually damaging the circuit. So we need to figure that part out. Maybe 1 or 2 cases of phrenic nerve injury across the million-odd patients that have been done. There's been 1 report of PV stenosis in a patient with pre-existing RF stenosis, but largely PV stenosis is not an issue. Recent reports of PFA interfering with devices such as ICDs and pacemakers. Sedation-friendly dosing, something that we really need in the field, is still an evolving thing in the world of PFA. And like I said, durability is still suboptimal, but then it's just the first generation of devices. And I'm pretty confident with the second generation of devices, this will be a lesser issue. Now I want to take you back to one of the initial concepts, which is reversible electroporation. And when we were in the lab with the preclinical lab with one of these catheters that we use today, called a FARA, we asked the engineers, hey, can we do something similar to what the biochemists and engineers used to do? Can we give a really tiny pulse and see whether that would cause reversible electroporation in the myocardium? And this is from the first slide that we did. We gave a really tiny pulse. This is way, less than 100 microseconds. And what we see are, these are the EGMs on the myocardium, and we immediately stun these EGMs. They get all far-field, and then over time, it recovers, suggesting that this was just temporary stunning. We then wanted to prove that this was actually not killing tissue. So when we looked at histology, we were ablating a little bit of tissue. This is like sub-millimeter damage. Largely the tissue is preserved. So we thought maybe this is a way we can interrogate circuits without actually damaging them. And I'll show you an example. This is just an example of a catheter delivering a reversible pulse. Look at the EGMs. They become small. And as this loop plays, in real time, you can see the electrical properties recovering over time. Okay, you can see how basically the voltage gets to about 80% of what it was. The next slide basically shows you an example of how you can use this pulse. So this is a circuit in the left atrium. We think that this is the critical part of the circuit. You give a reversible pulse, and the circuit terminates. That tells you that you're in a good site. I mean, we have current maneuvers that can tell us if you're in a good site, but this is a quick and easy way to tell if you're in a good site, and then you can use whichever energy you want to ablate the arrhythmia. I'm going to wrap up with the ventricles. This is the next area of focus. There's been lots of work already done in Europe looking at idiopathic ventricular arrhythmias, several publications and case reports trying to use off-the-shelf catheters for VT substrates that are refractory to currently available tools. There have been new reports published in Europe and a recent series here in the US suggesting that pulse field is here to stay in the world of VT. And this is data from a preclinical application of a novel waveform, a monophasic waveform, almost similar to a cardioversion, where you're delivering lesions in 150 microseconds. Now, it takes 5 applications, so that's 750 microseconds. Contrast that to a 3-minute long RF lesion that made a 6 millimeter lesion. And look at what you get. With a single lesion, you get 11 millimeters of depth. With 5 repetitions, which would be less than a second, you can get to 16 millimeters. This is an example of one such application in the left ventricle, for the first time allowing us to make an endocardial lesion that's transmural. And this data was then supported by clinical cases that we did in Prague, along with my colleagues Vivek Reddy and Peter Newsel. And here you see a large, I believe this was an ischemic case, and you see the endocardial lesions placed here. This was the epicardium before we ablated. You can see these signals, and after ablating in the endocardium, these signals are gone. And while this can be gone by another mechanism, we believe, based on consistent data across different patients, that these lesions were able to create transmural lesions. And the speed with which we can do this, the durability with which we can do this, seems to suggest that pulse field can finally be a quick and easy way of doing scar VT and make it more generalizable to the rest of the population. We always wondered about fat being such a great insulator for electricity. Surprisingly, we have found that pulse field, if delivered through the right catheter with good contact, can deliver current right through the fat pad and cause a myocardial lesion. So some areas that were always a no-no for catheter ablation may open themselves up with pulse field ablation. These, I think I have a slide or two left. These are the current tool sets. Every company, every startup wants a piece of the pie here. Every catheter makes a different lesion set. Our job is to understand what each lesion looks like, how many times we need to repeat a lesion, how best we place the catheter to get that best lesion so that our patients do well. So lots of excitement both in the microsecond space and in the nanosecond space. Everybody claims that one is better than the other. Time will tell. That said, I wanted to stop with this slide, basically summarizing a few points about the future of PFA. I think this will largely replace RF and cryo for most arrhythmias. The role of RF still remains when we're near critical structures like the His bundle, opposite coronaries, maybe for some SVTs, pediatric patients, radiofrequency will remain an option for most of our patients. We need to understand lesion profiles. You can't simply follow what the company says about how to use the catheter. You actually need to look at the lesions and say, well, this has gaps, so I'm going to do X, Y, and Z to make sure there are no gaps. You've got to make the best lesion because everything looks great at the end of the day. You need to make your best lesion so that 30 days from now, everything remains great. We need an improved understanding of arrhythmia so that we're just not doing the same thing but with a different energy source. This will not replace knowing where to ablate. So the science in EP is still there. We still need to understand mechanisms and do mapping. And yes, we need precision delivery. We can't ablate 2 inches of myocardium to get to one spot. That's not very attractive as an option. And we need to use responsibly, especially with this next generation of catheters that are so powerful. We can't just ablate to see whether the arrhythmia will terminate. We need to do the mapping first and then use targeted arrhythmias. With that said, I'll stop, and if you guys have any questions, I'm happy to answer them.
Thank you. Thank you, Jacob, for that great overview. I hope our administrators are listening and understanding why we are so enthusiastic about this technology. But I want to put some perspective into this, and I want to quote the late David Haynes, one of the leaders in EPs, that said famously that once you know a PFA system, you know a PFA system, right? So there's so many different catheter configurations, pulse wave waveforms, bipolar, biphasic, monophasic, and it seems to be that we are embracing kind of everything that companies give us, and it's up to us to really make sense as to which technology is more adequate for which patient. And in the context of these alarming signs that are showing, right, the diffuse spasm, is this something that is waveform dependent, that we can learn how to optimize what industry is giving us in a way that we can be safer? And I wonder what your take is on this.
Yeah, the late spasm, local spasm related to proximity is a class effect. This late spasm, which is very rare, so I don't want people to freak out, it's very rare. We don't know the mechanism. And other than giving potential drugs, vasodilators to prevent it, I don't think anybody has a good sense.
Do you think it has to do with a unipolar waveform, or it was?
Well, so far it's been described with all the commercially available catheters. So it's there with monopolar catheters, bipolar catheters. The only interesting thing that I've seen so far is a cohort published out of Arkansas of patients from the Marshall Islands. And like 5 out of 5 patients from that region all developed this sort of rare diffuse spasm. So there may be a genetic predisposition that's making some of these patients susceptible, but most of the case reports are from all over the world. So I'm not sure what the story behind that is.
Sachin.
Thank you for this wonderful talk. I'm not an electrophysiologist, I'm an interventionalist, but we also have a lot of new devices and tools that are coming our way, just like yours. And my question really is, yes, we all understand the science and the data behind this, but how do you sell this to your administration, when they are concerned about the costs and the margins in this, ever, complex world of margins and compensation and so on? Are there any disparities between the cost of these devices and the reimbursement from CMS? How do you navigate that in your institution? I know it's a loaded question.
I know. It's an issue that I luckily don't have to deal with, but what is very clear to all of us in the field is that this is a new frontier in cardiac ablation. The safety, the speed, the promise of efficacy is here to stay. There is no way we can go back and offer our patients, radiofrequency and cryoablation on a routine basis. On a case-by-case basis, these established therapies, I don't think they're to be discarded, but the safety and the efficacy and the speed allows you to do procedures in a safer manner, address patients that you would never take to the lab, older patients that you are generally hesitant to take, and it frees up time to do more cases. Our waiting list we thought would shrink, but it's just opened up more patients who can access these procedures. So it should really be driven by better care, and I think even with the high costs, the increased ability to do more cases has offset that cost, and hopefully with time, as more companies have devices, the competition drives the price down. But it's here to stay, so you might as well get on board.
Dr. Zaghi.
Thank you very much. I truly enjoyed it.
Thank you.
It gave the historical perspective and all the science behind it. I think you were so comprehensive, so congratulations. A couple of questions. One, Obviously, I'm not an electrophysiologist. So how do you, since you have reversible electroporation, how do you assess how much to use, and meaning your efficacy in the laboratory, since it may be difficult to differentiate the reversibility from non-reversibility? And the other question is, why is the interstitium and other areas spared? I mean, they still have cell membranes similar to the others. Why would they?
Okay. So the first question, there are several techniques being developed trying to tease out acutely what's reversibly electroporated and what's irreversibly. And we've been trying to do that for 20 years with radio frequency. Even RF had some reversible components. My take is that if you know the lesion size and the limitations of your catheter, you can design a strategy that has enough redundancy, because you don't pay a penalty for repeating an application. You make your lesion set so that it's durable the first time around. So the only way you know that is to do animal experiments, see this lesion size, you do clinical cases, and you remap them. You use a certain strategy, you bring them back at 30 days. It's easy to do in Europe, and it's being done all the time. And you remap these cases and show that this approach, this technique is durable. That's the only metric we have as of now. And I think it works. And I think if we did it systematically with all the catheters, we'd shorten this yo-yoing cycle that we've experienced with radio frequency. In terms of why the interstitium is spared, I should qualify, it's the collagen and fibrous scaffolding that's spared. And the only reason that's spared is because they are non-membrane structures. Anything with a cell membrane technically is electroporatable. There are subtle differences based on size, but if you ablate the myocardium, just about everything gets ablated that has a cell membrane. But the fibrous structure remains, which is what keeps integrity to the wall. It'll thin. It's dramatically thinned out if you ablate the entire myocardium, but it does not fall apart like necrosis from heat.
One other question regarding, compared to the radio frequency ablation, is the recurrence rate less?
So all the clinical data says it's equivalent. And the reality is, we are only talking about making good lesions. AF is a lot more than that. Ablation can only get us to a certain point in time. The other mechanisms still are not understood. But from a pure lesion standpoint, clinically, they look comparable. I think from a lesion perspective, this will win. Whether that'll translate to a huge improvement in our AF outcomes remains to be seen.
Here's up.
Thanks. This was an amazing translational talk. You mentioned some of the history regarding oncology and drug delivery. Have there been any thoughts about using reversible electroporation to deliver therapies to the myocardium, into myocytes, or any other areas that you guys have been investigating?
Now that I'm aware of, people have used reversible electroporation and delivered calcium and lidocaine to see whether it can amplify the effects of a pulse, but that's really not panned out. But specifically as a therapeutic target, no, not that I'm aware of.
One other interesting point that you briefly alluded to is the patient experience. When you take a patient for AFib ablation, particularly older patients with persistent AFib, complex substrate, that you end up doing a very aggressive ablation with radio frequency, we as doctors, we have to be ready to deal with that patient for a few days. They will get fluid retention. They will feel like really bad, a lot of inflammation. So you were putting the patient through a very stressful situation. Now we can do comparable or even more aggressive lesion sets with PFA, and the patient wakes up as if nothing happened. And that is one of the things that is changing, and I wonder what your institution is doing or what they're thinking in terms of moving the AFib ablation practice towards ambulatory surgical centers and scenarios where it's more of a daytime experience for the patient as opposed to coming to the hospital. And that has not just implications for patient experience, but for us, for the hospital finances, and for a lot of people. I don't know what you guys are thinking in that.
Sure. Yeah, I mean, I would second the patient experience. It's been amazing for our patients. They're so much happier. They don't have the typical chest pain. Like you said, nobody coming into the ED with heart failure. But importantly, when a patient calls me, which is much rarer now, with some vague chest pain, I'm not freaking out thinking, oh my God, is this going to be a fistula? That peace of mind to me is so special that I'm never ever going to use radiofrequency in the left atrium unless I'm forced to. So I think those sort of benefits are difficult to sort of capture in papers. In terms of ASCs and the outpatient experience, look, it's round the corner. If we aren't doing it now, then someone else is, and we'll all be doing it soon. And if we don't use these tools and figure out which tool will allow us the most easiest path for an outpatient experience, will a balloon-based PFA that allows sedation only be the right path, or which tool is... We need to figure these things out so that when the time comes to switch many of these cases to an outpatient setting, we're ready to go. And it's only a matter of time that happens where we are at. New York has some really complex rules for ASCs, but we do know of neighboring institutions that have already started to do this.
Dr. Laurie.
Dr. Laurie, I'm a cardiac surgeon here. Enjoyed your talk very much. We are heavily involved in the surgical ablation of cardiac arrhythmias, and I was particularly interested in the transmurality and size of these lesions. We did 120 map-directed VT ablations using a computerized system we built here, which was from Matt Kruger, who was our engineer at the time. His name you probably recognize. And what we found early on was, number one, epicardial mapping in VT, ischemic VT, was not reliable because of the dispersion of signals from the central subendocardial problems. And then number two, we did a lot of work on cryo, and exactly as you described, it doesn't penetrate very well, and we came up with the concept of bi-surface ablation going from the epicardium and the endocardium. Each lesion took 2 minutes, and we'd be doing 8 or 10 lesions. And it requires a wide ablation. And what I'm really coming to is the fact that at the height of our skill level, we were doing VT with a 95% cure rate and a 1% surgical mortality. And just at this moment, the defibrillator arrived. So immediately, all the cardiologists and EP people totally abandoned surgery for the defibrillator. And then when the transvenous defibrillator came, then it was even not a topic of conversation. But I continue to be struck by the fact that a number of these VT people who have defibrillators implanted and have to stay lifelong on medications and put up with the occasional VT episode with a shock. Now that you've got pulse field ablation showing from an endocardial standpoint excellent transmural ablation and with a big lesion, that it would be worth seriously revisiting the topic of using pulse field ablation for VT rather than automatically diverting to a defibrillator.
Yeah, I think clearly the studies are already planned, and some of these catheters that I showed you are already in